first session in this year's Buffalo's Future Series. I'm Dr. Ken Maker. I'm the president of Medaille College. I like to use that doctor part even on a night like tonight, even though I'm not a real doctor, as my family continues to tell me. So, kind of doctor that doesn't do anybody any good, but you know, hey. We are happy that you made it here. I want to thank our presenters for taking the time to prepare and participate in tonight's presentation. Dave Anderson, Dr. Michael Edbauer, Al Hammonds, and Dr. Stephen Schwaitzberg. John Crawford will do a little bit more of the bio introduction in a second. Tonight we're facilitating, our conversation will be facilitated by one of Medaille's own, Michael Hughes, a class of 2012. We're very happy and thankful to have him with us tonight. Confusion, complexity, and soaring costs. Higher education, no, wait a second, we're not on higher education tonight, are we? No. That might be one way to define today's healthcare. When I was growing up, my daddy always told me, you know, you want to keep things safe, you know, if you're ever in doubt, talk about the weather, talk about your health. Well, with climate change debate and healthcare debates, I don't know if those are safe topics either these days. So, the mission of Medaille College includes promoting civic engagement in a healthy, diverse democracy. So being able to address the topics of the day that have their own set of controversies and challenges is certainly in keeping with the mission of what we try to do here at Medaille College. Consider that in the United States, roughly $3.4 trillion was spent on healthcare in 2016. Business owners on average shoulder 80% of the cost for their employees, and that amounts to an average national cost per employee of over $12,000. So in my view, that makes healthcare a big deal and something we need to address in our Buffalo's Future Series. Today we hope to shed some light on this very confusing topic and the topics that have evolved over the last 6 minutes if you've been watching any of the news feeds. We'll take a look at the pending changes in healthcare, what they mean for Western New York, and how the Affordable Health Care Act has already impacted us. Hopefully our esteemed panel will help enlighten all of us on the status of the nation's healthcare system. And speaking of enlightening, that is just what we try to do at Medaille through the Buffalo Future Series. Through this free series, we've endeavored to provide community service by discussing topics that are relevant to Western New York. And tonight is no exception. We've looked at issues such as the shortage of workforce, recent construction boom in housing, the impact, and we've listened to notable speakers such as Eva Hassett talking about immigration, Dr. Triner Cash talking about the new bargain for education here in the city. And today's conversation is one more in that list. The series will continue in 2018 with 2 more programs. In February, we'll look at how businesses cope with disaster planning. In the spring, we'll talk about energy consumption and how it relates to the environment. So thank you again for being here tonight and joining us for the Buffalo Future Series for 2017-18. Before we move on, I would be remiss, because I have the microphone, to talk to you about all the opportunities that Medaille College has in store for you. So we do have a full suite of programs, as you can imagine. We're very proud of the students that we serve. Roughly slightly more than 2,200 students between here, our Rochester campus, and our online campus, including programs all the way up to and including graduate programs in psychology, mental health counseling, marriage and family therapy, and a doctoral program in psychology as well. Our business programs, as do all of our programs, provide students with an opportunity to learn in a way that's most convenient for them. And so now I'd like to introduce our VP for College Relations, who will present our panelists, Mr. John Crawford. Thank you.
My name is John Crawford. I'm the Vice President for College Relations here at Medaille. And before I introduce our panelists, and I would ask the panelists as you're introduced just to come on up to the stage, I just want to throw a couple of shout-outs there to our new trustee and friend, Julie Snyder, BlueCross BlueShield, who helped us put the program together tonight. Thank you, Julie. And a good friend and trustee, Horace Joya, who I love. Where's Horace?
Right here.
There he is.
How can you miss him?
He doesn't have the time. Horace Joya, who this whole series was Horace's idea 3 or 4 years ago, and it's it's our contribution, just one of the contributions that the college makes to the Western New York community. So, so today it's my privilege to introduce the panelists, and I will say these are very brief introductions because if I were to go into everybody's background, we would never get to any kind of panel discussion. We would just be here all night talking about these fine folks. Dave Anderson. Dave, why don't you come on up? Comes to us with BlueCross BlueShield of Western New York as a seasoned health insurance executive with a strong track record of successfully engaging and managing organizations. He has served as president and CEO since 2013. Welcome, Dave. Dr. Michael Edbauer. Dr. Edbauer, why don't you come on up? Is not only the president and CEO of Catholic Medical Partners, he is also their key architect in creating the organization's clinical and quality improvement agenda. Mike has been leading CMP since 2006. Join me in welcoming Mike. In his leadership role as Executive Director of Millennium Collaborative Care, Al Hammonds leads a team who collaborates with physicians, healthcare providers, and community-based organizations to positively impact Medicaid patients across Western New York. He is a certified Six Sigma Black Belt practitioner too. Let's say hello to Mike. Finally, our panelist with the longest title, Dr. Stephen Schwaitzberg. Steve is chairman of the Department of Surgery at the University of Buffalo Medical School and Biomedical Sciences, and professor of surgery and bioinformatics. That is a mouthful. He is an internationally recognized physician, investigator, and has been in practice for more than 20 years. Please give Stephen a round of applause. Our moderator tonight is Mike Hughes. Dr. Baker already introduced Mike. He is the Chief of Staff of Public Affairs and Marketing for Kaleida Health. Very talented and intelligent Medaille alum. Let's welcome Mike. Okay, before I turn it over to Mike, let me just remind everybody, as you walked in, you should have gotten some index cards and a pen for the question and answer session. So every 15-20 minutes or so, you'll see one of our student ambassadors down in front to collect those. So just write your questions down as we go through, and again, just look for the young Medaille ambassadors down in front, and they'll grab those from you and bring them up to Mike. Turn it over to Mike.
Thanks. Sir. I appreciate it. Thanks. Thanks, John. Welcome. As the invitation for tonight said, healthcare is a very complex issue and one that's very hard to predict, whether that's currently or in the future. There are lots of changes being discussed, and depending on whether you're a physician, or on the hospital side, insurance side, or other, those changes may come with great peril or welcome relief. Healthcare is also a huge economic driver for the West New York community. So we, as a community, collectively watch with great interest what happens in Washington and Albany. So tonight we'll ask our panel of healthcare experts to weigh in, help us discern fact from fiction. More importantly, hopefully their insight will be informative and help you make the best decisions for your company and your employees. So with that, we'll start right off and get right into the politics. I'm going to start by asking each of the panel members to talk a little bit about what's going on in DC right now. All kidding aside, we can park the politics and just really focus in on the debate. There's an awful lot going on in DC. That's been healthcare has been a topic for over 25 years in Washington, probably highlighted by the Clinton administration, and hasn't stopped since. So I'll start with Dr. Edbauer. Talk a little bit about the current debate in DC. Is it helpful? Is it not helpful? Where do you see this going?
Well, I think the greatest challenge that we're seeing right now is the uncertainty in Washington. So over the last several years, actually for the last decade, Washington has taken a stronger and stronger lead in healthcare as it relates to us even on the local level. So much of the policy that happens at the federal level comes down to the state, affects the local market, and has really had an impact. And regardless of whether you are pro or against the whole idea of the ACA, there was clear direction, a pathway, and if you will, the rules of engagement were pretty well understood, so you can begin to define how to be successful in that environment. The challenge with the most recent administration is that there's right now not a great deal of clarity about where things are going. And in fact, that can even change, appears sometimes day to day. And so trying to understand exactly what those rules of engagement are has become a little bit more of a problem. Having said that, the one thing that I believe, at least from my perspective, that remains is that the movement towards value-based care remains unchanged. So I think one of the things that is hopeful is as we look out, we still ultimately know where we need to go, continuing to move away from fee-for-service or fee-for-volume, moving towards the value-based care. The challenge is knowing some of the specific tactics that are going to be most successful based on the rules and regulations that we're trying to implement.
David?
Well, first of all, I agree with the stability comments. Healthcare is very prospective, and as a health plan operator, we are essentially done for 2017. We're probably halfway through 2018, and much of our focus is on 2019 and beyond, actually. And a lot of reasons for that, but that's kind of the time frame that health plans and providers work together on when we're looking ahead. And with the instability of Washington, D.C., it's very difficult to manage your company and manage our relationships in an effective way when we don't even know what the rules are going to be in 2018 and 2019. So this instability that's been created has a ripple effect throughout the whole healthcare system. With that said, one thing I'd like to mention is that New York has always been a very progressive state in regulation of healthcare policy. Probably one of the most, the other being California. Those two states are probably the most regulated healthcare environments in the country. There's good and bad, of course. But because of their aggressive regulatory style in New York State, these are very kind of round numbers, but about 80% of the regulations that affect our company and affect you as a member of a health plan are really determined in New York State. Washington, D.C. gets all the headlines. But the reality is, much of what is being discussed in Washington, D.C. has either already been implemented in New York or may not really affect you to a great degree. Also, much of those headlines are about the individual marketplace. So individuals, they're either going to an exchange or in some way purchasing their health care coverage for themselves, not an employer marketplace. And just as a point of reference across the country, the individual marketplace represents only 7% of the entire healthcare marketplace for membership. So what my point would be, not that it's not important, not that it should be disregarded completely, but understand that the majority of the regulations that will affect you and the providers and ourselves are really determined in New York State, not Washington, D.C.
Al?
I'm looking at it from a slightly different perspective. Overseeing a collaborative is overseeing a lot of the Medicaid redesign in the state for West New York. The changes in the volatility in Washington really drives a lot of uncertainty with the disproportionate shared hospitals. So the safety net hospitals, so for example, Erie County Medical Center, which is the parent organization of Millennium Collaborative Care, will be deeply impacted because it serves the underserved, the underutilized, the low utilizers in the Medicaid population. Those folks will be in harm's way if we don't get this thing figured out. So we're trying to drive reform in our organization and transformation in the Medicaid population, but all this uncertainty, if these cuts go through, multi-million-dollar impacts to the budget of a safety net hospital, like Erie County Medical Center, like Niagara Falls Memorial Medical Center, and even and even hospitals down the southern tier as well. So it's pretty serious, but we still got time to get our
Dr. Schwaitzberg, from a physician perspective?
Well, I came from Massachusetts and took over as the designer of surgical services in the last public hospital system in Massachusetts. At that time, there was a free care pool that basically paid cost of charges. And when the Romney administration took over, I was there for the implementation of Romney Care, and which is an advanced form of Medicaid, obviously. It gave everybody a health insurance card that was deemed to be a good thing, so you could turn around and say 98% plus people had an insurance card, but it had a lot of good consequences and other consequences. The good consequences are to really encourage the disadvantaged populations to come and get preventive care. And that's a great thing, because providing ability for people to get good care is actually good business at the same time. Taking care of people who have advanced diseases, advanced cancer, breast cancer, colon cancer, other forms of malignancy, bad heart disease, is not only bad for people on a human experience, but it's also bad business because it's very expensive. We then transitioned from Romney Care to the Affordable Care Act, which was not a lot of change because the states have a lot of sway over how they interface the federal government. The bad side is it only pays 30% of the cost. So while we have reduced the cost to the federal government and to the states, we also really hurt the hospitals badly. And that's where here it's district, there it's DISD, there are these buckets of money to try to make up the deficits. And I can tell you that when you have a bucket of money, it becomes a target. So we had a bucket of money to make up the deficit of the difference between cost and charge. And immediately one day we were informed that we were about to take in 2 weeks a $50 million pay cut. Well, that would have destroyed the last public hospital system. In Massachusetts, it would have sent 40,000 emergency room patients from one of our hospitals to downtown MGH and Brigham. And that was the unintended consequence. Here in Western New York, and I'm really thrilled to be here, it's turned out to be really a phenomenal place to live, and I really enjoy it. But what I've seen is in this 8-county system, there's a lot of people who are underserved. There are a lot of people who are disadvantaged. And I can tell you, I've seen more people come in with perforated colon cancer in the middle of the night and septic shock in 1 year than I saw in the previous 20 years. And we need to be able to get that high quality care, not just in our city, but throughout our region, so that people can get colonoscopy, so that people can get breast cancer screening, because prevention really works. And I've seen tragedy after tragedy after tragedy because people don't have access to the care, and we need to improve that. So these cuts in Washington may save money in a budget cycle, but the long-term ripple of the financial burden of caring for these people will cost somebody much more money than we will.
Thanks. So through the original Affordable Care Act debate all the way through this past summer, there was a lot of talk about the insurance coverage piece. So Dave, I'll start with you on this one. So you live close to Canada, so we're going to ask about the single payer system. We recently had one of our congressmen talk about Medicare for all, or reducing the age eligibility for Medicare. Talk a little bit about where we are as a region on the insurance side, and the pros and cons of both of those ideas, single payer versus maybe something like reducing the age for Medicare.
Yeah. Well, and there is more discussion about those two options, probably more now than there has been in the last 10 years or so, simply because of all of what I would call the nonsense or the craziness that's been going on in Washington, D.C., because it brings about a question of whether you can solve these problems. And but I think those ideas are very interesting to look at on the surface. We have to go below the surface of those to begin to see whether they're viable or not. First of all, single payer is not a new idea. The reality is the Medicare Advantage marketplace and Medicaid are effectively forms of single payer already, and we administer those. And all of our network providers are involved in servicing those plans. So if the reason that we have not gone to single payer, typically around the country, for what we call our commercial or private payer marketplace, is because we've chosen not to. We think that there are better options associated with it. Also, one of the things that it would do, single payer would do, particularly for the provider space, is it would set fee schedules that would reduce compensation and fee reimbursement to doctors, hospitals, everyone involved in the healthcare space. There is no other way for it to save money other than to pay out less in claims. If also we believe that if in fact that the government were to take over as a full single payer option, there's no infrastructure that is there simply to administer the health care to the membership. There is a certain amount of administration that has to occur. There is administration in Medicaid. There is administration in Medicaid. That same kind of administration, meaning someone to call on the other end of the line when you have an issue, would have to be built. And currently, the government, both at the state and federal level, has made the decision that we are a better administrator for those programs than they can do for themselves. So to simply impose a government option in the commercial health insurance space without that administrative capability means the day that it happens, there's no one to call. And not that it couldn't be built, but whether it could be built cheaper and more effectively than the administrative systems that are in place now, I highly doubt. But given that, as I've said, we're not against single payer in concept, because we are a contractor for single payer in two very significant segments, Medicare and Medicaid.
Dr. Edbauer, talk a little bit about what David had mentioned in terms of being paid on the quality side. You mentioned value-based care earlier. David talked about having more funds available for the health system for the reimbursement side. So talk a little bit about the shift that you had to kind of steer in your organization, where you had physicians traditionally were getting paid based on volume. Now you're moving towards outcomes.
Yep, so this is still a work in progress. So this transition that's occurring, there's still a significant amount of payments that still come in under the fee-for-service component. It's beginning to move towards adding in components that are related to the value outcome piece that's at the various areas of whether it's Medicare, commercial, or Medicaid. I think one of the things, I want to kind of piggyback a little bit on David's comments, that one of the things that has to be recognized, and Dr. Schwaitzberg spoke about it in his opening comments, is there has to be an acknowledgement of the true cost of care. So it's one thing to say what a reimbursement is going to be, but it has to align with the true cost of care. As David very accurately pointed out, government programs right now are actually typically the lowest payers. So the commercial products actually are paid much better, are more expensive, and it's partly a cost shift because there isn't enough money in the bin to pay for Medicaid, so there has to be higher payments in some of these other areas to basically equal it out. So one of the things that I would hope that our government would look at, and as we advocate for policy changes, is rather than focusing on whether we need a single payer or the broad marketplace we have, is to look at some of the true levels of cost of care and making sure reimbursement fits to the level of the cost that actually is occurring. And part of that also is looking at the rules and regulations. A piece that I think is often overlooked is the waste that occurs in healthcare. When we talk about waste, often people think we're talking about things like an unnecessary lab test or something like that, which may occur. But there's huge waste that we all have both on the payer side as well as the delivery system side because of the regulations that are in place. So all the boxes we have to check, the amount of time and effort that occurs within the the office, the hospital, and the insurance companies that does not directly affect patient care. And those are really imposed upon all of us at the level of the government. So I think that's an area that we don't want to miss as we too much focus on whether we should be a single payer or not.
You talked about the cuts earlier and how devastating they could be. Talk about some of the things that your organization has done or some of the other organizations similar to yours and why that's a benefit in the current healthcare system.
We're one of 25 different performing provider systems in the state. The Catholic Medical Partners has a system like ours. We work really close with community partners in Western New York. So we work together. There's approximately nearly 400,000 Medicaid recipients in the Western New York area. About 1 in every 3 people who live in the greater Western New York area across the 8 counties are on Medicaid. So what we're trying to do is we're trying to break down all of these silos of healthcare, and we're creating a clinically integrated network where we can take electronic medical records and communicate them in the cross provider systems, primary care and behavioral health, and post-acute arena and all that. And we're using data analytics to drive it. So we've got the community partners has a more mature system. We're building it at Millennium Collaborative Care. We've got about 260,000 attributed lives, as they call them in New York State, and we're building a clinically integrated network based on data analytics. So what we're doing is we're taking the social determinants of health, like transportation, food, housing, and we're integrating that into the system to make sure that to prevent avoidable ED visits, because the highest cost of care is when people go to the emergency room and they have a backache or stomach ache. And that just drives the system out of whack in terms of cost and in terms of the volumes. So our whole initiative is to reduce avoidable hospital visits and hospital admissions by 25% or more over a 5-year period. That's what we're working on.
Right. So Dr. Schwaitzberg, aside from your lengthy title there, you do don the scrubs and the mask and you go into the operating room. And you do clinic hours as well. Why is the work that as organization that the Catholic Health System has, why is that important for a physician in terms of continuity of care and taking care of patients?
Well, in order to take care of patients, you need information. And even in a city, in a market size such as this, information is scattered all across at least a half a dozen silos. And as we develop, as you know, we're developing a cancer program at Kaleida, and we put down all the different medical records that a patient would need to touch to navigate their way through the system. It's up in my blackboard in my office. You should stop by. People come in and take pictures of it. And you just go, there's waste. It's inefficient. And waste isn't about an unnecessary operation. It's about repeating the CPC. It's about repeating the CAT scan. It's about sending you home because I don't have your CAT scan. It's about the disappointed look on your face when your doctor promised that they would send your record, and I promise you if it shows up in my office, I will have it. They only need to carry it 5 feet. And so we're hampered by information. We're hampered by the differences in our population that might be affecting outcomes in Western New York versus downtown Miami Beach or Boston or other places. And if we're really going to pull costs out of the system, we need better information. I see complex patients every day. They come from Dunkirk, they come from Olean, but they also come from Williamsville. And I look at patients every week and go, I'm sorry, I'm going to have to see you back next week. I know you had a CAT scan. I don't want to repeat your CAT scan. Please bring me your CAT scan. Those kinds of things we have to do better. And so we need to really come together as a region and expand the capabilities of Healthy Link, really try to consolidate into 2 or 3 systems so that if a patient comes to me from CMP because I provide a unique service that may not be available in their system, they don't have to delay their care, repeat their care, and so I can provide the best service to whoever needs it.
We're going to move on to technology and quality in a minute. But before we do, one last question on the Affordable Care Act. David, I'll ask you. I'm sure you get asked, and you have since the law was first passed. Is the Affordable Care Act a good thing, bad thing? But mainly in Western New York, what does it mean for Western New York? And how do you explain it to a customer that may ask you, a business executive that you may insure their company? Is this a good thing for Western New York?
Well, it will depend on, first of all, there are good aspects of the bill, there were some not so good aspects. And then it would also depend whether it's good or bad, whether you're a commercial employer providing coverage, or whether you're in the Medicaid or Medicaid and Medicare section. So it does affect each one of those. The way that the bill causes the funding to change inside of those segments, so you have to kind of go below the covers a little bit and determine how that is to work. But if you're an employer-based model, I just make a broad statement and say, quite honestly, it didn't have a big impact on Western New York. Primarily, as I mentioned before, many of the aspects that you read about under the ACA were already in place in New York already. In the way that it funds Medicaid, it has been fairly dramatic and has been onerous, and that has created instability. In the Medicare market, not too much impact. As far, I always get asked, should you repeal and replace, what should you do? And I would say our position is that it should not be repealed, that it should be adjusted, but you should work within the law that exists and change it for the better, and to make, but to throw it out and completely and start over during that period just adds to the instability, which I don't think makes a lot of sense. So I think that's essentially been our position. And then the last thing I'd say is that the Act originally did a lot to help access to care and to bring many people that were in the uninsured ranks into the system. And it created an opportunity for individuals to make individual decisions about their insurance. That's what the exchanges were all about. Which are all good things. And it defined pre-existing conditions and other situations like that, which of course we had already enacted in New York. But those are good things. What the Act did not do is it didn't deal with cost. It dealt with social access issues, but never dealt with the issue of how are we going to deal with costs. It really ignored the actual cost structure issues inside of healthcare. And that's where we have to go. Any act going forward is, in our view, has to deal with payment methodologies, funding of the segments, and the actual cost of care.
So we'll stick on that. So Dr. Edbauer, talk a little bit about, as a leader in one of the major health systems, you too have that same issue of cost. Not only you guys deliver care, and you have to make sure that your patients have access to care. You have 7,000 to 8,000 employees that they need to be insured as well. How do you guys deal with the cost issue?
So it's a very challenging situation, and David and I were actually talking about it a little bit earlier this evening. It's really requiring, when you look at an issue of reduced reimbursements relative to the cost of delivering care, you have to really start looking and saying, how do we change the delivery model in order to do it in a more cost-effective way? And part of that is something that's relatively easy in the sense that you can start to deliver care in new settings that are lower cost. So that it's some of the things that I was talking about, when you start taking things from an inpatient setting, taking it to the outpatient setting. The challenge at the same time, however, is maintaining some of those critical services that are necessary within the acute care facilities that now have less of the other work going on alongside them. So if you get sick and you need to come to the hospital with that perforated colon that Dr. was talking about before, you want to have a top-notch emergency room, top-notch surgeon, an excellent critical care team in the hospital. And all those are very expensive. And And if that is now the majority of what the hospital is doing because other things have moved out, the core business of the hospital actually becomes more expensive per person. So you have that component associated with it. That over time can be dealt with. The other challenge is that you have fixed costs as opposed to variable costs. So there's certain aspects of the care that's delivered that you can't simply take out because now you have 70% of the amount of volume as you had perhaps a year or two before. So if you have a physical plant, a building, that building is still, all that expense is online. You have the variable costs of needing fewer nurses, fewer staff, etc. But some of that fixed cost is still there. It takes a much longer period of time to take some of those fixed costs out of the system as opposed to the variable. And what hasn't been well described, and I think this goes to David's comments in the ACA, is what assistance could government give as we go through these changes in the healthcare delivery to help the delivery system switch some of those fixed costs out and remain viable while they go through that transition. So there's many aspects of the changes that are occurring, and it's still very much a work in progress. So I'll completely answer that.
Al, pick up on this point of taking costs out of the system. That's what your organization, not only on the coordination side, is designed to do, but your goal is to take costs out of the system. Talk a little bit about that, and then also, how are you guys measured? What does the state expect from you? What type of reporting mechanisms do you have?
I'll start off with the second first. We have a very onerous reporting process that we have to go through with the Department of Health. Because the delivery system reform incentive program, DSRIP, which is what our organization is part of, it's leveraging both state funds and funds from CMS and from Medicaid and Medicare. And so because of so much public money, federal money, state money, we have a lot of reporting requirements. So we have 54 different pay-for-performance measures, HEDIS measures, claims-based measures, what have you. And then within that, we tried to skinny them down for our particular system to about 16 priority ones that touch a lot of different areas. The behavioral health performance measures are the ones that are the most challenging, and if we focus on a lot of the behavioral health measures and the mental health measures, those are the ones that make the biggest impact. So a lot of our efforts are around co-locating behavioral health and primary care. But right now, I know it was mentioned about the regulations here in Washington, in New York State area, is New York State's working on trying to relax regulations around being able to co-locate behavioral health services into primary care, and primary care into behavioral health. That's a big deal because most people have both behavioral health and like a person that has diabetes also suffers from schizophrenia or depression. We see that particularly in the Medicaid population. So we desperately need, so we're driving transformation in that arena to try to drive improvement. And then the biggest thing we're working on is using the data analytics to drive the care management and care transitions with community health workers in the community. And really trying to build those community-based systems and alternatives, focusing on the social determinants of health, focusing on population health, taking care of the whole person, not just one segment. So we're working on a lot of those kind of numbers.
Great. Let's talk a little bit more about quality. David Anderson from the insurance side, Dr. Schwaitzberg from the physician side, you're relying on the quality agenda. Dr. Schwaitzberg, you want your surgical program, you want the best surgeons, highest quality, best outcomes. David from the insurance side, they want to make sure that their enrollees have the best access to the best physicians available. So talk a little bit about the quality agenda and how you have seen in your career the need to move to all things quality. And I'll have David follow up with that.
Oh, great. So I'm a fan of Freakonomics. And if you follow Freakonomics, we are all products of our incentives. If you quote Lucian Leake, who is one of the world's most renowned experts in healthcare quality, every system is perfectly designed to get the results that they get. So whether it's our system or anybody else's system, the results that you get, that's because that's what you're designed to do. in the current systems that are based on volume, the incentives around volume, people make their living, feed their families based on the responding to the current incentives. They're volume-based. If we're going to change healthcare and think about what's important for the future, we have to change the metrics, which means we need real discussions about what the metrics should be. We haven't done that. We haven't had a discussion in America about how much healthcare is a right and how much of it is a privilege. We haven't had that discussion. I agree with David that the Affordable Care Act was about insurance reform. It wasn't really about health reform. It didn't address tort reform. A lot of things were missing from the bill, and none of these things exist in a vacuum. We didn't talk about education reform. If you want a better doctor, you start with a better medical student. We had a conversation in the back about investing in K through 3. So if you want to change healthcare, it starts in the nursing schools. It starts in the medical schools. It starts in the pharmacy schools. It starts in the way we educate and train people. They live in silos. We need to educate them together because in the future they're going to need to work together. So the metric for economic success for many physicians to be the busiest physician, because that's what the system incentivizes. We need to figure out a way to incentivize people to be the best physician, because we've demonstrated in some of the work in the literature that the physicians are actually worth the same amount of money, could save millions of dollars of healthcare costs and improve their outcome by changing the incentives. I'm not one of those people that says the doctors are overpaid. Personally, I don't think many physicians who train for 12 years, who will be there for you in the middle of the night, who stand there in pool of blood, or who spend hours talking to a patient about their psychiatry, I don't think they're overpaid. I think our system incentivizes the wrong behaviors that drive up costs in ways that aren't in our best interest anymore. So we need to reward quality. We need to have a system that doesn't turn to somebody and say, we can't make that doctor unhappy, he's the busiest guy in the hospital. What we need to have a conversation is, we can't make that guy unhappy, he's actually the best doctor in the hospital. And those are the conversations that we need to have in the future. So I recruit for quality. They may not be the least expensive salary, but they may be the least expensive healthcare for the future. I recruit on temperament. I recruit on patient satisfaction. And those are the determinants that we can line that up with a set of incentives that will hopefully change over time to produce the best healthcare results for everyone.
David, talk about it from the insurance side, why you're aligned with the hospital system on quality. We have all the incentives with the Catholic Health System, with Kaleida, with Rouse, with DCMC. Talk a little bit why that alignment is important.
Well, quality of measurements are critical and tied into this movement from fee-for-service to value-based payments. Historically, when we reimburse on just the fee-for-service volume basis that we talked a lot about tonight, there's no real incentive for anyone to really look at quality, because it really didn't matter how good of a job anyone did. You got paid the same amount. It was based on the service, not on the outcome. And so this move to value-based payment methods between the health plans and the provider system, the quality measurements become critical for that, because it becomes the basis for how they are reimbursed for that particular procedure. And so we are moving towards paying for outcomes instead of paying for the service that is done. Meaning that outcome, if that outcome is of a higher quality and a better result, the payment for that will be higher than if it is not. That has historically not happened within our healthcare system. So the other thing that we, from a health plan, just to be very tactical about it, we believe there are areas already that, and we do operate and pay for quality within populations, such as the immunization rate. Are we getting them done, particularly in a pediatric setting, for a number of members and percentage that are receiving, that are accessing preventive care and wellness methodologies within that population? A follow-up after hospital discharge. Is a follow-up done, and what's the extensive nature of that? How many within a population are getting their annual checkups and an annual health risk assessment done by their primary care doctor, we can actually monitor those percentages within populations of those things being done and know that that will produce a better health result for that population. And if those things are done, then we would reimburse those provider systems more as those percentages rise. So we would incentivize the quality of that population management process. That's relatively new. We've got a lot of work to do and we're just, that list I just gave you is still fairly rudimentary in our view. But it is beginning to extend into more complex procedures such as joint replacement and other things of that nature where we have enough volume of procedures to actually have metrics around quality. So we are aligned, and that's basically what we are. Much of our focus is in our contracting methodology in
So, Al, I think people would be surprised to know that your organization is not just about coordinating care and taking costs out of the Medicaid system. I think people would be surprised that quality is a major initiative for you guys and how you guys have it as a major focal point of what you're doing. So, not something that traditionally linked together in the media or healthcare is that quality and Medicaid, never really are connected. But talk a little bit about how you guys organize on your agenda around quality.
Yeah, we address quality by looking at targeted populations. So we look at different, we do hotspotting. So we take the zip code, the highest penetration, the highest utilizers of Medicaid patients going to the ED. So for example, 14215 is basically the highest concentrated Medicaid population in Western New York, across all 8 counties, and they have the highest number, the highest volume of emergency room visits that go to your sisters, or ECMC, or Buffalo General, whatever, one of the larger hospital systems. So we focus on targeted populations and hotspot zip codes, and we look at how are we going to take care of that population. How are we going to put together community-based organizations with a community-based primary care providers, with behavioral health organizations, and then, like I said before, using data analytics to drive our decision-making, to put together care management, care transition processes, actually developing workflows, doing the continuous improvement to drive better quality health care, and to actually to move into this value-based payment methodology, going from the fee-for-service to value-based. That's what we're doing with these targeted population focuses using our data analytics. We're seeing the beginnings of progress being made in these hotspots in cold areas that we're focused on. It's really been cool to see. We really focus your efforts.
Dr. Edbauer, question for you, and then I'll ask Dr. Schwaitzberg to weigh in as well. Proponents of the repeal and replace, they talked about competition and its ability to help reduce healthcare prices and improve quality. Our organizations have been healthy competitors for decades and decades. Talk a little bit about the competition piece in Western New York, where competition is healthy and then where sometimes we need to collaborate.
So I think competition is healthy. It really goes to the idea of if you are looking to improve your situation, you want to be able to be successful in the relationships you have with payers. So for example, when David was talking about moving to these quality-based programs, if you don't have sufficient competition in the market, there's really no need for a system to move in those directions because they can continue to really dictate a fee-for-service mentality. So having that competition, I think, is very positive for the overall community. It creates innovation amongst the competitors, which then ultimately are copied. Someone comes up with an idea, the other entity sees that, you move forward and continue to raise the bar for all members. So I think that general concept of having, I think we would suffer if we had, for example, only one healthcare delivery system within Western New York. Flipping that though to the other side, to your point, there are certain areas where the collaboration can really provide great opportunity for the community. And I think we've had a great example of that last year, the opening of the cath lab up in Niagara County. So that was a collaborative effort between Kaleida, Catholic Health, ECMC, and Niagara Falls Memorial. It's a type of project that probably 3 or 4 years ago we would have said was impossible. But basically, by bringing all of those competitors together in a setting, we were able to address the medical needs of the community that, quite frankly, has very, very high rates of coronary artery disease. So to be able to have a cath lab in that vicinity that's co-operated by all those entities has really been very positive for the community. And then that also starts to be a nidus beginning to look to see, are there other areas that we can expand upon that might be at the level of dealing with things of preventing heart disease. And quite frankly, I think that's where, as Al mentioned before, the work with the 2 PPSs between ECMC and Catholic Health has worked very closely together to try to make those improvements. So I think that there can be a proper mix of competition, but there also, we need to continue to look for those areas of collaboration.
Dr. Schwaitzberg.
The founder of Boston Scientific is a fellow named John Aveley, and he, after retiring from being the chair of the board, opened up a center in Toronto called the 90 Group Center that is dedicated to the management of competitive collaboration. And it's really a genius concept where we want to optimize for all parties. An example is UBFD surgery provides acute care services as responsible because of the aging of surgeons in the heart and replace surgeons. We've got a team that's perfectly suited. So we collaborate to optimize for both groups. Where competition sometimes is wasteful is in the medical arms race. And former head of the hospital of Beth Israel Deaconess has a blog called Not Running a Hospital. And he talked about the desire to not buy a robot, for instance. He tried very hard when he was the CEO to not buy a robot because there's actually no data from many things that the robots are used for that they actually improve outcome. What I've written about in the past, particularly for outpatient surgery like gallbladders and hernias, despite the prolific marketing campaign by industry, is all you do is lose money. All we do is waste money. And until we have a metric where somebody can say, here's where it's a better outcome, or here's where we can do it at the same price because the doctor dropped this price, we compete. So we buy a robot, so you buy a robot. So we buy 2 robots, then you buy the newer robot. Because you have the newer robot, I better get the newer robot. And all of us are losers in the medical arms race. And that we need to be more data-driven. We need to be more outcomes-driven. We have a lot of process measures. We need more outcomes measures. And so I've put a lot of thought in this in the last 10 years. We've dedicated our department to developing tomorrow's leaders today to look at these entities. If we look at over the last 30 years, the number of physicians that have increased in America is not very much. The number of administrators in America has gone up really dramatically. And part of our solution is we need to get providers. They could be nurses, they could be pharmacists. My thing is the Department of Surgery, so we do our little part. And so we are training surgeons to get MBA. We're training surgeons to get MPHs. We're training surgeons to become experts in biomedical informatics. We're training surgeons to get degrees in education so that we can all participate in the movement to value-based care, because most of the surgeons will be employed. They need to work in the system. They need to be able to talk the same talk you have in terms of looking at data together, so we're not making emotional decisions. We're making rational decisions. And then we need to call to the other side of the street. Do we really all want to buy, 4 more robots this year at $2 million a pop? When you think of what he could do with $8 million, we have got to free ourselves to some extent from the medical arms race. Now, I'm not a Luddite. I'm a technology person. A Luddite is a person who throws sticks in the machine, and that's called sabotage. But what I am is looking for the value to make technology do things to improve healthcare. And there's a million great examples of where we've spent money to save money. But we should not be competing in areas where we're doing it because of an arms race, because of a billboard. We should be doing it in places that are better.
We have about 5 more minutes left before we start taking questions from the audience. David, you came here from California. Give us your sense of how Western New York has embraced healthcare as an economic engine or as an economic force here. There's an awful lot of construction. UB Med School is moving down to the campus. We're able to recruit better physicians who may have not come here 10, 15 years ago. Nursing schools are beefing up. So talk a little bit about us, the healthcare system as an economic force.
Well, I think it's number two in the whole region as an economic force. So from an employment standpoint, investment, and a capital generation standpoint, it's very significant. And much of our economy in Western New York revolves around the healthcare delivery systems that we have here. I came here 4 years ago, which was really at the kind of after the start of the medical campus development, which has continued on for the past 4 years. And it conceptually is a smart idea. It brings the various resources and environments in closer proximity so that they can be linked in ways to work more effectively together and begin to deal with some of the waste in the system that we've talked about. It also creates an access to the research facility that is always vital for both the university system and for specialty care. So I think that's all good. I will say I have concerns about, if we're just coming in from the outside and looking at Western New York, that we have overcapacity and that we have been a little bit of an arms race mentality at times that the doctor talked about. And all of that infrastructure has a cost associated with it that then has to be borne through the premiums that everyone pays and the healthcare costs that everyone pays. And I think as good as development is for Western New York, which was on the decline for many decades, and as anxious as we are for all of that to happen, we also have to be mindful that we may, in our healthcare space, we may be overbuilding, and I think we are. And we have to be rational about how much infrastructure cost are we really willing to pay for as a community. And at this point, I think my opinion is we're paying for more than we need at a time when healthcare premiums are going up every year. So I think I think that has to be a very frank and rational discussion that the community needs to have.
Dr. Edbauer, picking up on that, so your organization has made tough choices over the years in terms of the amount of beds that a certain hospital would have, or services, programmatic offering. So to David's point about the overcapacity issue, how have you guys addressed that in terms of trying to take costs out of the system while still trying to serve your patients?
Yeah, this goes back to my earlier comment saying that one of the things we recognize we have to continue to look at trying to remove some of the fixed costs within the system, which is really what they're referring to. And we have certainly the number of beds within the system, and actually in Western New York as a whole, have been diminished over the last 10 years with the closure of some facilities. For us, a big one is kind of now a footnote, because it's so long ago, the OLB hospital was a very significant closure given where it was in relationship to Mercy Hospital. And I think as we look at, continue to look at programs, we actually made a very conscious decision to actually make investment in IT resources, because we actually felt that growing the IT capabilities was going to be more important in the long term than some of the physical plant structures, given where healthcare is going. Looking, we believe, to a more distributed model where people are going to want to have their care close to where they live, whether that's oncology services, even things like orthopedic, which used to be a mainstay of hospital care. More and more of that is now occurring out in communities. So having that connection through a very robust IT system to be able to provide that care in these multiple settings and also reduce your costs at the same time. So some of that is already occurred, but I think we have to double down on those efforts and continue to look to bring some of those fixed costs offline.
So my last question before we move on to the audience questions, I'll ask each of you is just to give us an elevator speech about where's healthcare going. before this started, we were talking in the back room, and home care came up, the EMR came up, telemedicine came up. So where do you see healthcare going as it relates to you as a physician, you in the PPS, you in administration? So talk a little bit about where healthcare is going.
So I think that we're going to need to regionalize care. And I slightly disagree with David is that I don't think we necessarily have overcapacity here as a central hub. I think we're seeing downsizing, as we talked about earlier, places like Dunkirk, Lowlands, because you can't, there's not an economic model that gets all of those specialists. When you think about the treatment of rectal cancer has changed a lot in the last 10 years, and in some countries you may travel 6 hours to get your rectal cancer bypassing 100 small hospitals to get to the place where they do it best. So for me, if I had to place a bet, I'm spending a lot of energy trying to build a hub-and-spoke system to provide surgical services to the 1.3 million people in the 8-county region. And how do I get surgical services to Dunkirk? What part of it can be done there? And to do that, I need better IT, I need telemedicine, I need great communication so that I can get the right specialist in the right place, and we'll get the generic surgical specialist to do a bigger bulk of the work so that the parts that need to be done by the in-city specialists are limited to just that piece so patients can stay in their communities. And I'm a specialist, but it's a different problem with primary care, and it's a different set of issues. But I don't have enough people to do thyroid surgery in every hospital in the 8-county region. That, I don't have enough people to do complex foregut surgery. So we need to regionalize some of these services. Big discussion in American surgery about we need a certain volume to be good at complex things. And so I think that we may actually wind up getting a little bigger because that regional movement for things that have to be specialized, but I'd like to provide as much of that care to the community as I possibly can through better systems.
Now, where's healthcare going in your world?
The progress and change has already started. The pyramid has to flip. So instead of hospitals being at the top of the food chain and all the dollars and all the services going downstream, it's got to flip. So it's got to be primary care, it's got to be at the top. Primary care has got to be the hub and the core where everything happens. And from there, that's where you feed, that's where everything has to be connected. Through primary care and through behavioral health. It's got to be that way. It's the most affordable care. It's the way we take care of populations. It's what we've already started. And it's going to be a tough culture change. I mean, I've had the privilege of being in other industries other than healthcare. And this is the last industry that hasn't had radical changes like the finance industry and not-for-profits and all that. And it's going to happen. So that changes. It's coming.
Edbauer.
I'm more on the same page with Al. I think the changes that are going to continue to occur are really at that level of in the primary care and in the community. And something we haven't talked about a whole lot tonight, a little bit indirectly, is the social determinants of health as well. We can talk about technology, we can talk about where the care, as far as in centralized areas, etc. But our real goal is to try to prevent a number of those people from ever needing that care. And it goes back to the comments we're talking about, you have to start at that the kindergarten, first grade level. It is something that will be measured in decades or generations, but many of the disease states that cost us a great deal of money and cause a great deal of morbidity and mortality in our country are preventable. Some of them, simple ones that you're all aware of, such as, not having someone smoke, less abuse of alcohol, better exercise, things like that. And those are things that, I think Al, you said it very well, that really has to be where the focus of what we want to look for towards the future. Now, having said that, we still have to balance it with taking care of all the people who already have all those diseases at the present time, and that's one of the real challenges. But I do think we've started to see, and I think we'll continue to see, growth in that movement towards looking at that prevention of care, education, and those social determinants of health, but it's going to be a long road.
David?
So I would answer a little bit differently. As to where healthcare is going, it's going here. 2007, we entered the mobility age when the iPhone was and smartphones were invented. And what that, just as to support that argument, the biggest capital in the healthcare space over the last 3 years have been Amazon, Google, and venture capital. They haven't been health plans or provider systems. Now they're doing that for a reason, just because what they're looking for is a significantly disruptive model over the model that we have today. And the benefit of that, there's a number of benefits associated with it, is that you've heard us talk about linkage and data and having the right data at the right time in the right place against an extraordinarily fractional business of healthcare. And that level of infusion of capital from firms such as Amazon and Google will have the ability to create that kind of linkage foundation that it is very, very difficult for us as individual plans or provider systems to do. But where it leads, I don't know if we know at this point. But I would expect that within the next 3 to 4 years, there will be a significantly disruptive model that will be very individually focused as opposed to being employer group focused. And that there will be capabilities for you to monitor your health and your wellness on your phone, and this also using a level of artificial intelligence, which is also now being developed, that your phone will be able to assist your entire diagnosis when you go to see your physician. And how we reimburse for that, how you provide insurance for those services will be challenges that we'll have to face.
I know we're at the hour mark here, but we do have a few questions, so if I can, I'll ask, and I'll direct them to one of you here. So, Dr. Edbauer, have you addressed this? What are healthcare providers doing to improve continuity of care for those dealing with opioid addiction? And then, David, what are the insurance companies doing to make sure that there are fewer denials of coverage for these patients?
So the opioid epidemic obviously is a huge issue. There's actually been a lot of work going on, and actually I would say it's something that we're doing exclusively. It's something that's really done across the community. Dr. Cal Burstein is someone who's a real champion of this, and we're very fortunate to have her in her role in Western New York. But what we have been doing, she has really spearheaded, but this is going in conjunction with university, Kaleida, Catholic Health, really everyone across the board. Great deal of training of providers to be able to start treating patients, identifying patients in a more timely manner, and then treating them, whether it's with Suboxone or, again, one of a lot of press, expansion of methadone clinics, etc. So recognizing that we have to increase the capabilities of our community to treat the individuals who already have addiction issues, but also going back to my comment earlier, moving downstream to increase the awareness, and that awareness is at multiple levels. It's to the population, so people are not sharing pills or understanding the risks of using some of the pain medications, but also very much responsibility back on the providers to be a little bit more cautious in how the medications are prescribed. And I think we started to see a significant improvement in that area, which also has to be balanced with, we run our dialysis too. Start to get to the point where there's some doctors who don't want to prescribe any opiates, and sometimes they do have a place, and so there's this balance going forward. So I think that there's actually a lot happening in the community, and as I said, we're fortunate with the leadership that we have, but again, this is going to take time. We probably still need about 3 times as many providers that we have today to really deal with folks with addiction, to take care of the population that we have. We have a huge waiting list for people waiting for those programs.
David, on the insurance side?
First of all, I think that was a very good summary that we have tried to support as well, and work with Stephen and his group as well. Our company initially started the Painkillers Kill, and if you remember seeing the big billboards all over town, the Painkillers Kill campaign, that we then also went to the legislature and identified the nature of the problem from an awareness standpoint and helped to change prescribing procedures in the state. So we've been involved in it for quite some time. We work with our providers very closely and removed authorization, prior authorization techniques around that and allowed those decisions to be made at point of service. And we have also financially resources in order to make sure that they can meet the demand. And a couple of them, just to stay open, we've actually supported them financially. So I think it's been a good partnership for the community. I think we've had an impact. We still have a long way to go. It's a very difficult problem.
So, this problem has become this generation's Vietnam. Everybody in this room knows somebody who has died. Some people talk about going to their 10th, 11th, 12th, 13th funeral. It touches families, it touches all socioeconomic barriers. And my wife is the assistant dean, working with the IPE group and really working to educate clinicians, specialists, everybody's involved. We used to think that our goal should be nobody should ever be in pain. So we're all responsible. Regulatory agencies should incentivize people to give pain medicine. We are all to blame. We all have a role. And we had a professor visiting today. He said for his colon surgery, big surgery, they are now able to manage 60% of their patients without any narcotics, using everything from preoperative techniques to alternative medicines. Medicines like Celebrex, which are not routinely approved in the past, need to get approved because it's better than the opioids. And I think that we all need to make this number one immediate health crisis. Short term, it's more important than cancer. This is our Vietnam, and we need to all be a part of the solution.
Al, a question from the audience here for you. What would you suggest smaller single physician chiropractic offices do to prepare for either district or value-based pain?
Collaborate. They need to figure out if for chiropractic, there's got to be a whole, if we're going to be taking care of populations, the specialists, the community, there's a private primary care physician offices, there's a lot of collaboration going on in the chiropractic world with primary care, co-locate with primary care, behavioral health, and form some alliances and partnerships. That's where it's going.
Last question, I'll open up to anybody on the panel. Do you see value in a single quality model for hospitals and providers? A unified quality model for hospitals and providers.
I think it would be a great idea. In my previous job, I was a network executive, and we would look at the measures for BlueCross, and we look at it for Edbauer, and we look at it for United Healthcare. And we were just making crazy by all this, and we'd go, why can't these guys get on the same page and agree? And even if they had the same measure, the thresholds were different. So we would really appreciate it if we could come to consensus as a payer group to what the quality should be.
Well, truly, you just adopted BlueCross BlueShield
And I'll take it further. It's not, we actually, quite frankly, over the years, we've gotten a lot closer with the payers actually asking us to look at the same metrics. I'm not saying it's perfect, but I would say compared to 10 years ago, there's much more alignment. What I find very frustrating is that there are so many different agencies out there who have decided they are going to rate all of us, whether it's U.S. News or Business Week or what have you, health grades, you go down the list, and these are all companies who actually make their living out of evaluating different components of the healthcare industry. And there's been a few states, Wisconsin is one, where they put together a community health collaborative, where all the providers in the particular community have agreed that they will only use one set of metrics for quality. And basically, they're governmental type of metrics. They're not as sexy as 5 stars or 3 of this or what have you, but they're very specific. They're on a website. And there's also an agreement amongst the community that no one will use the information for marketing. So what you can do is you can market to push people, to push the consumer to go to a website where it's very factual information, so they can see where the quality is and to understand the differences. And it's also required that, if, for example, if my institution was the best performer in an area, you are required to share with everyone else within the consortium how you were able to achieve those outcomes. Because the idea isn't to be better than someone else, it's to bring everyone up to the same level. So what it did in those communities, and there's several of them, where you no longer have billboards touting, best this, best that. It kind of talks about the arms race issue that was talked about before, but rather it pushes the consumer to a single source of knowledge relative to quality within the community. And it also reduces the cost for the entire healthcare delivery system, because everyone isn't trying to cater to all these various agencies that are measuring. The one caveat to that is we are all required to a certain degree to do metrics for different governmental agencies. It goes back to my earlier comments that we need some reduction in some of those regulatory requirements to streamline the process. And both the American Hospital Association and the American Medical Association have put together a joint statement relative to this to try to reduce the number of metrics in all these various different agencies that measure so that things become clear across the country.
With that, we are out of time. I want to thank our panelists here. Thank you all for attending.
I want to double the thanks, gentlemen, for your contributions tonight. Michael, thank you for your moderation of the event. As I was listening, we do have a gift for you from the college for participating tonight. As I was listening to these comments, I couldn't help but hear the parallels to my industry. That higher education, perhaps like healthcare, not perhaps, higher education like healthcare is a right and not a privilege. And when we think about co-pays and deductibles, for a lot of students that we serve, a textbook has to be weighed against rent or food, and the challenges of serving the underserved populations of Buffalo and other areas around the country. And lastly, the rating system. The college scorecard and all the U.S. News and World Report's rating institutions, and we all serve different clientele. And so it's in a lot of ways it's a very challenging industry with some interesting parallels. Thank you all for joining us tonight. We will have additional topics in our Buffalo Future series, so look forward to seeing you at the next events. Drive safely home. Thank you again.